We can just title.
Hi, everyone, and welcome to an Unfiltered podcast. And this one sort of just happened on the fly. I told Cindy as we were chatting this morning that she needed to rewind and cue this up again. What happens when you get in the house and you see the patient for the first time with a face to face in your hand and it does not match what you see in front of you as the actual patient? Cindy, go.
Well, my issue, Sherry, is that, the face-to-face is such an important issue when it comes to compliance. And we work with a variety of agencies that have, made so many processes and steps and checkers, check and checkers to make sure everything is lined up the way it should be from an office perspective. But far too often, where is that admitting clinician in this conversation? Because we can gather information at the time of the referral to the best of our ability and have an attestation and have all of those pieces. But I go out as the clinician and I'm in the home with the actual patient. And I realize that the primary reason put on all of this documentation does not align with what I'm seeing. That could be what puts you in the hospital. It could be a very significant issue for you, but I found out something bigger, something more of a problem, something that's going to need me to alter this focus of care. And why am I going to see this patient and what other resources do I need? And we have got to get the clinician to understand, as a healthcare provider, as a professional part of this team, it is my job to reach back out to the physician's office and talk about what I found. This whole, I just put down the primary because that's what came over, and then the checkers, check and checkers. Oh, everything lined up. Look at that. It's all lined up. We're all good. Check all the boxes. Our face-to-face is fine. Where it will bite us is when you start looking at the execution of the care plan, because it is going to go the direction of the patient need, or at least it should, because then we're really talking about, why are we seeing this patient? So now we've set ourselves up for a problem. Yes, the face-to-face looked all good at the beginning, but now we look at the care plan. Oh, yeah, it lines up too, but the visits don't even talk about the same thing. And doing some recent auditing, Sherry, it's astounding to me to look at it and say, well, the primary says this, the plan of care talks about something completely different, and the visits talk about a third thing. And I think a lot of times the solution is we got to pull everybody in the office again, at intake, at referral, at the person assigning the, yes, all of those are integral pieces of it, but we cannot leave the clinician out of this conversation because they have the latest and greatest boots on the ground information. And we can make all the guardrails we want, but if they're not engaged in that process, as well as the rest of qualifying criteria, yeah, oh yeah, they need a nurse, they need therapy, but do you qualify to have this in your home? I think we do talk about these qualifying criteria when we orient a new person. But do we talk about it on the regular after that, that everybody beyond the admitting clinician, PTAs, LPNs, home health aides that are out seeing this patient need to know what those qualifying criteria are, because maybe the patient no longer meets homebound. And that's not a bad thing. We're not trying to make people stay homebound. But our eyes and ears throughout this episode of care are critical to say, yes, there's a specific time point where we get hyper vigilant on to start a resumption of care to make sure all of these things are in place. But where's the team in monitoring that going forward?
Cindy, that is so true. And you need to have a process in your agency that when there's a mismatch between that face to face or that PMH that you got, the past medical history that you got from their previous facility or from the hospital, when it doesn't match the presentation of the patient, what are you telling your clinicians to do at that point in time? Are you telling them to just finish the start of care blindly, hand it back into the office and let them figure it out? Because if you're doing that, you're losing some crucial time, not just in how that patient is going to be cared for, but what you're able and legally allowed to do with that patient without a physician's order. For example, patient comes in, they come in for CHF exacerbation. They were in the hospital where they were diuresed and they lost 10 pounds in the hospital. And so you think you're going out to see a CHF patient, and what shows up is leg wounds, weeping all over the place, extreme edema with ulcers on their lower extremities. Are you allowed to treat that without a physician's order? No, you're not. You have to call the physician. You have to get some guidance on that. And what we used to do in the agency that I own, Cindy, is that was an automatic trigger to schedule an appointment with the primary care physician for that patient. That was our policy and procedure. When there was a mismatch with the face-to-face, the first thing you do is get on the phone and go ahead and schedule a follow-up visit for a new face-to-face, because that's the other part of this. The face-to-face has to match what the plan of care, what your plan of care is written for. The diagnosis on the face-to-face has to be the same as your lead diagnosis on your for what we call a 485. You're on your plan of care and on your certification. So there's some regulatory issues here, but there's also some clinical practice issues here, isn't there?
Yes, and I would go one step further. And again, everyone who's ever heard me before knows that I'm going to say I am not a coder. I don't pretend to be one. But I think part of what gets into this process as well is when I go out and I do identify that there's a different focus of care, and I do address the clinical risks of saying, I don't have orders to treat X, Y, or Z, let's get a physician's appointment and all of that. But then sometimes what I get privy to as part of the work we do is, well, the coder came back and told me the primary is this. Wait. The coder came back and changed your primary. Um, this needs to be because of PDGM. Okay, whoa, back up. There needs to be collaboration between the clinician and the coder. This is why that narrative summary is so important, to clearly define what is the focus of care, what are the relevant secondaries. We see that a lot in our outsourced services, Sherry, where the narrative is just doesn't have it in it. It just lists a bunch of random things, or, there's a framework to it that the organization came up with, but there's nothing in there talking about focus of care. And our coders are like, what am I supposed to do?
The cat is sweet. The dog's name is Cinnamon. There's a 14 other
Yes.
things in that narrative that have nothing to do with the plan of care. But good, go ahead. I'm sorry. Some of the ones that we read are quite flowered with excess information, but don't have stuff that gets to the point.
But there again, I think it's an opportunity to say, how engaged have we been in that collaboration element? Not, thus saith Cindy Kraft, this is what your narrative should say. But why would we not sit down as a group of clinicians and a coder and say, what do we all need to be communicating here? What is the purpose of this narrative? It's not just words to put in a box, but we're trying to summarize and focus care so that the coder can translate what you're saying into the right code. Not the coder's job is to pick something off of this laundry list that came on the referral source, and let's make sure it hits something in PDGM. And oh, since they picked it, now I'm just going to arbitrarily put it as my primary because I don't want to be a coder, so I just let it go so it's consistent. That just ends up with a snowball effect. And I think a lot of it, again, we see organizations try to fix this by making office-driven guardrails and who's checking the checkers of the other checkers, and miss the clinician. And so I guess that's my key point today is, as a clinician, I need to be engaged. I can't just say, I'm not a coder, I don't do this, I just go out and admit patients. No, you have a huge responsibility when you do that. And if we work together, then we're not just doing busy work, we're doing what needs to be done to best represent the condition of this patient. And we don't have to have so much back and forth and sideways trying to massage this, or having it get caught later on an ADR and go, oh, how did that happen? We need to make sure every element of this is engaged in the process.
Absolutely. Thanks, guys, for attending our podcast. And if you want to hear these kinds of podcasts, this kind of real talk, subscribe to our YouTube channel. And thanks again, Sen.